Welcome to the Endpoints podcast, presented by the ALS Therapy Development Institute. I'm Jonathan Gang. Dr. Danielle Boyce is one of the newest members of ALS TDI's science team, recently coming on as our principal investigator for real-world evidence. She brings with her a wealth of experience in analyzing big data about ALS. Her role will involve working to glean crucial insights about ALS from the vast data collected through ALS TDI's ALS Research Collaborative, or ARC, study. Today, on Endpoints, Dr. Boyce joins us to discuss how data science can help us learn more about ALS, and why she believes data available through the ARC study presents a particularly intriguing research opportunity.
Hi, I'm Danielle Boyce, and I'm the principal investigator for real-world evidence at ALS Therapy Development Institute. My background is mostly in data science, data engineering. For many, many years, I was a data analyst and biostatistician at Johns Hopkins on staff. I have a master's in public health with a concentration in epidemiology. So I was well suited for that work and really enjoyed it. And along the way, I had an opportunity to do a lot of data engineering. So working with early electronic health record data sets and real world evidence, just as that field was starting to gain prominence in our work and with some of the big vendors for electronic health records. And then I had a child with rare disease. My son Charlie, who's now 14. And so that made me want to learn more about how data works in the context of regulation, the regulatory environment, and just all things related to bureaucracy. So I have a doctorate in public administration. And now I am working full-time at ALS Therapy Development Institute, leading some of their real-world evidence efforts. And I am also on faculty at Johns Hopkins and Tufts University, where I teach and develop educational programs for the next generation of data scientists like me.
Dr. Boyce's relationship with ALS TDI began as an outside collaborator. She says that she's very excited to move into a full-time role and to continue to dig into the data from the ARC study.
Yeah, I've known about ALS TDI since I started working in the ALS space roughly about 5 years ago. I've known many people who participated in fundraisers, for example, or who would talk about ALS TDI on social media and all the neat things that they're working on. And I was very intrigued. When I first met Fernando, I was the executive director of the Packard Center and of the ALS Answer ALS research program. And so I was very interested in how we might collaborate because Answer ALS is a big study that is now ended, and the ARC study is also a large study that is continuing. And so I was very interested in how we could work together for the good of the entire community. And so we kept talking, Fernando and I kept communicating and trying to think of ways we might collaborate. We crossed paths in various meetings, mostly patient advocacy type meetings where we would be invited as researchers and scientists and also advocates to come together and learn more about the priorities of the community. And at one point, after I had left Packard and was doing other things in big data, I met with Fernando, and we had identified a funding opportunity at the Centers for Disease Control and Prevention, CDC, for their ALS registry project, where they fund researchers who have interesting ideas. And so we said, how about we analyze the ARC data and put in a funding opportunity for that? And we did, and we won it. And so for a year, I worked on that project with Fernando and his wonderful team while I was at Tufts. And I had moved over to Tufts by that time. And so we worked on that together for a year there. And I was so impressed with the quantity and quality of the data and the commitment of the team members. with the ease of just working at the organization, the support that I had received in the work that I wanted to do, and just the collaboration, the spirit of the team, all working together for the right reasons. And I jumped at an opportunity when presented to take my full-time role at ALS TDI, and I've been just really happy being able to have the freedom to do the work that I'm doing with the full support of the team and everyone doing things for the right reasons. It's really a dream for someone like me.
Dr. Boyce says one of the most appealing parts about joining ALS TDI is the many different kinds of data that have been generated and continue to be generated by the ARC study.
You might hear a term multimodal, data, and this is tossed around a lot. What this truly is. So these are all kinds of different data types, all brought together. And it poses a lot of challenges and opportunities too. And I like both of those things. As a biostatistician, I get excited about analyzing and understanding and interpreting my findings. But as an engineer, that part of me gets excited about how I'm going to harmonize it all and put it all in the same place so that I can analyze it and do biostatistics on it. So there is a core data set. So when you enroll in the ARC study, you fill out surveys about your risk factors. And so we have survey data longitudinally, meaning every 3 months people fill out their surveys, and they're prompted to fill out on all kinds of things, their family history, their hospitalizations, the medications they're on. Some people have kits at home with equipment for accelerometer, and some people participate in voice recordings over time for kind of sub-studies. At least that's as I understand it. But there are sub-studies where they participate in these other studies that include tools, and we collect all those data. And those are in kind of a different format than just a survey, because you can imagine if somebody is giving a voice recording, that's very different than if somebody's just filling out a questionnaire. Right? And people also have the option of having phlebotomy, blood draws done at home. And so a kit is sent out to folks and a phlebotomist, and so they collect blood, and that is analyzed. And so we have data on that. And so those samples can be turned into all kinds of different types of samples that I do not personally work with directly. I work with them indirectly because my work is in the support of that work. So iPSCs, you'll hear more about on other podcasts, I'm sure. iPSCs, all the omics, the suite of omics data. And we also obtain data from a subset of participants since 2023 from their electronic health records. And so that's really my area of focus.
These electronic health records are Dr. Boyce's specialty, and using them to learn more about ALS will be one of her most important projects in her new role.
So these are the types of data that get me up in the morning, and I'm very interested in this. And the reason why I'm interested in electronic health record data is not just because it's just a huge playground of data that I get to use all my cool data science tools on and open source tools on, but it allows us to capture information that is collected routinely, but that can help us to understand disease progression and outcomes, but also risk factors. And other things. Think about all the things you talk to your doctor about that might be documented. There's no way we would burden you to directly answer questions about all of these things, and nor would it be easy for you, for example, with a pulmonary function test. It wouldn't be easy for you to take the results of a test that you may or may not have ready access to, that you took at the hospital or the doctor's office, which you probably do on a regular basis. It helps to track your breathing, right? There's no way we could ask you to accurately pull that information, transpose it, enter it in directly, however often it happens when you go to the doctor. And so these are the kinds of targets that I have in going after these electronic health records. The other one is a big one is your ALS FRSR, your ALS functional rating scale score, which is the most common used outcome measure in ALS clinical trials. And so therefore, of great interest for us to follow and track. Now, the ARC study does ask you to fill this out at home, but that doesn't necessarily correlate with all of the times that your doctor in a very theoretically highly controlled environment asking it of you the same way is asking it, and possibly, for example, for a clinical trial you might be in, is asking for that reason, and it's documented in your chart. And so those two things alone make that electronic health record data really gold. And so my priority as in my role this year is when you enroll and consent to have your, which is optional, the consent, but to consent to have your electronic health record data pulled into your ARC study data set, my goal would be 1 month between the time you consent to have those data come in to the time we have data that we can actually act upon, processed and ready to go and are merged with the other survey data and blood sample data and all those other things that you have. There is such a rich amount of data in the EHR that we really have to focus and not get distracted. As a researcher and someone who loves this stuff, it's easy to get distracted and think, oh, look over here, look all these interesting things that I'd like to, look into, or look at all the artificial intelligence tools. But they're tools, not toys. And so it's very important for us to really focus and prioritize and use the best tool for the job, and think about what would be immediately useful, which would be those outcome measures and measures of functional ability. And then concurrently, we're looking at other things that we can extract. For example, family history is often captured in a very detailed way. Other medications that you might be on that might not be captured in your ARC questionnaires, that might be of interest for drug repurposing, for example. So that's kind of the overview of all the types of data and the things that I'm working on. And then just one more thing, we're working with Pat Dolan, who is the leader of GeoALS, a nonprofit dedicated to mapping ALS in all kinds of ways. And we're using tools that he has to help understand residential history of the people in the ARC study and what environmental exposures that they might have had, because we don't all know. Not everyone knows exactly what caused their ALS. A lot of people don't know still. And so certainly environmental triggers have been hypothesized. And so to follow up on some of those leads from the literature, we can do that with mapping, because we can obtain data sets from EPA and others that indicate your exposure to certain chemicals and metals and such in the environment. So that's something else that we're doing with the CDC funded project as well.
Dr. Boyce says that streamlining these EHR data for use in research will be a big undertaking, but the potential insights we could learn from them are extremely exciting.
So I'm really excited right now about just how we are leading the field, I think, in ALS real world evidence, and how we are extracting data from these EHR records. I think that has been the most exciting part of this so far. Coming from the world that I come from, I work with all the leaders in this area. And so I've had the benefit of being aware of all the ways that they're extracting data from electronic health records. But I never really did it myself, beginning to end, because I always worked with these groups that had huge engineering departments. And so it wouldn't have been my role to convert all the electronic health record data into another format and develop software and such. But here at ALS TDI, since we're such a much smaller group, I've had the opportunity to do those things myself. And so I've been able to really translate the work that I've observed from these top groups to a nonprofit's data set. And talk about rewarding. And ALS TDI is so deserving of that. But most organizations don't have that opportunity. And so, uh, for example, when the data came in through electronic health records, they were not going to say messy because that's the nature of these. They're meant to be look messy, but there's tools that when the EHR data is sent from, let's say, one hospital to another, there's tools that are used to extract it all and organize it. But when it's sent to a research group, they don't necessarily have those tools because we're not a hospital. So we don't have think about like Epic EHR data. You send from one Epic system to another, it all pre-populates all the fields and you can see what you're reading. But when it comes to us, it's in this kind of innate native FHIR or CCDA format. And those are just formats that were invented to transmit the data. So in order to kind of parse them out so that we can understand and use them, I was able to develop a software tool in RShiny, which is open source, free. Anyone can use it. And that has come out of this collaboration. And so then once we did that, we looked a little further and we realized, wow, a big part of the important stuff seems to be in this unstructured data. And so these are like encounter notes. So think about it. When you go to the doctor and the doctor writes up a summary of you, they don't necessarily put each little piece that they're learning in a separate little spreadsheet field. They're kind of writing a paragraph, but you don't analyze paragraphs. You can't put 6 paragraphs in and make like an average, right? into your software. You have to take out the numbers from the paragraph in order to average them out, right? Think about tax software. You have to have the numbers each in their own cell. You can't put a word in there. And so that has been my task. And not only has that been part of the task, but also to identify those items in standardized vocabularies. So, when you go to the doctor and they give you a code, a billing code, for whatever it is that you have. And there's a number like an ICD code or a Loink code, RX norm, every medication you take, procedure, condition that you have has a code in the electronic health record. And if it doesn't have a billable code, there are other ontologies that the National Library of Medicine uses called common unique identifiers that can flag it. So for example, if you say you have cold feet, this came up in another project I was doing. If you have cold feet, that might not be something that the doctor takes the time to code, to look up what is the code for cold feet. But if it comes up in unstructured data, I'm able to find that with tools that I have for the common unique identifier. And so why that's important is it means that we can use these open source tools to tag every single word in a note, every single phrase. And you have to kind of play with it to get the right blend of not too many words at the same time, not too few. But what it means is then you can work with large language models, which is something that we're setting up now, to feed what we know about the data into the large language model to help us to restructure our data automatically. So we're developing this pipeline. When somebody has a paragraph or a note, it gets processed through a tool that tells us all the unique identifiers that it can find, all the ICD codes, all the RX norm codes. And then we can process those data with machine learning for insights. We can also convert it to a common, what's called an OMOP, common data model, observational medical outcomes partnership. So we can put it into a standardized format, which allows us to work with other people who have their data in the same format, and we can kind of combine all of our data for analysis purposes. And so all of these things are available to us right now. And we are navigating things like making sure we're using only tools that will not reveal patient information, right? So we need to protect HIPAA type of thing, right? So we're making sure that privacy is protected. We're making sure that they're accurate tools. Big one. If you've ever used ChatGPT, you know it hallucinates. So it does the same thing with data. So you have to be mindful of that, right? But ultimately, like I said, the dream is to be able to have every piece of data that could possibly exist on each patient and study participant available if we need it for our analyses, and never feel like, oh, I wish I knew. If it's available, we have it.
None of this research would be possible without the people who generously share their data with ALS TDI through the ARC study. Dr. Boyce says she's thankful for the opportunity to work with these data and deeply appreciative of the people with ALS and asymptomatic gene carriers who provide it.
Yeah, so the ARC study is truly the most extraordinary research study I have ever had the privilege of working on. And I have been in this field for about 30 years. I have never seen such a comprehensive study. And there are so many data points, so many different ways to contribute, and so many opportunities to dive into this study, which is why it's really important that we share it on the ARC Data Commons. So any researcher who has an interest in studying the ARC data can go to this ARC Data Commons, and with a data use agreement, and they can receive de-identified data. So your privacy is protected, but the researcher can dive in, and I think that is so important because there's such a rich data set. Now, since 2023, people participating in the study can also consent to have their electronic health records automatically pulled into our data set. And that is a game changer for ALS, in my opinion, because now we can fill in all the blanks of the things that we just don't have time. You don't have time to answer every single bit about every single doctor's visit, every single test you've ever taken, every medication you've ever been on, but your doctor has that information. And so those data points are automatically pulled in to your record that I am able to then analyze. And my goal within the next few months is to develop a pipeline that pulls in crucial data from those electronic health records and merge it with all the other data that the scientists at ALS TDI are using within 1 month. So from the time you consent and the data are pulled in to the time it's in the hands of the researchers who need it, 1 month. And that is my goal for this year, and I'm making Fernando and team hold me to it, because it's really, to me, it's not enough that I say I have this interesting tool and aren't I special that I am able to analyze data with AI, and that doesn't mean anything. It doesn't matter. It doesn't matter. The ALS clock ticks. So what I need to do is in my job is to get the insights out of those data, however I need to do it, whether it's with AI, but oftentimes it's the old-fashioned way. And so for people enrolling in the ARC study, it is such a valuable way to contribute, especially for many folks who do not have clinical trials that they're eligible for. This is a way to make meaningful impact in the field. And from your home. It's not even something that you need to do at a doctor's office. And I can say just from my own lived experience, I have a child, my son Charlie, who also does not have a lot of clinical trials to participate in because of his advanced condition. And so observational studies, natural history studies, and registries like the ARC study are such a valuable way to feel like we're giving back and helping scientists learn from our experiences as well. And so I want to thank everyone who participates. I am blown away by your dedication. When I go into the data and I find that people have been contributing every 3 months for years, I am just so grateful and humbled by that. I have never seen that before in my whole career. So thank you.
If you're interested in being a part of the research described in this podcast, consider enrolling in ALS TDI's ARC study. Anyone with ALS or asymptomatic carriers of an ALS-related genetic mutation can join. Participation is free, 100% remote, and can be done from anywhere in the world. To learn more, visit als.net/ARC. Thanks for listening.